left off. Interesting, I was in the back there listening to the last 2 hours of lectures, so I realized it's a long morning sitting in lecture all day. So, but I think this gets interesting as we get into more clinical information here in neuroscience. So we talked about the posterior limb of the internal capsule and the genu, and now a little bit about the anterior limb. And this gets difficult because now we're talking about pathways that don't relate to things we've talked about yet. The CPCT here is the corticopontocerebellar tract. That's a pathway that we will talk about later. It's important in terms of connecting the brain with the cerebellum. Okay, there is a pathway here we're going to talk about in just a few minutes called the anterior thalamic radiations. And right here, FEF, remember that from the frontal lobe, the frontal eye fields, this pathway that has to do with eye movements. So to travel from that area of the frontal lobe down to the brainstem to move cranial nerves, well, it has to get there somehow. And so it gets there through this portion of the anterior limb of the internal capsule. Right? So these are the pathways you need to know that are in the internal capsule, and they will all be much more relevant to you here over the next week or two. Okay, so we have projection fibers, and we have association fibers. And association fibers connect areas on the same hemisphere. And there's just one example that I'll give you for now. It's called the arcuate fasciculus. The arcuate fasciculus connects these two language areas that we've just mentioned briefly, Wernicke's area and Broca's area. And it makes sense that those two would be connected, right? You're in conversation with someone, they say something to you, you're going to understand it here in Wernicke's area, and you want to say something back, and then there's a connection, a program that goes from Wernicke's area to Broca's area, and then you're able to respond. Okay, so that specific pathway is the arcuate fasciculus. Okay, here's just a little cartoon drawing here. Many drawings of Wernicke's area will only show it on the posterior portion of the superior temporal gyrus. And remember, that is the most important area of Wernicke's. Okay, and here's a dissection showing you the arcuate fasciculus fibers here. Commissural fibers connect the hemispheres. Okay, and so we've talked about one already, the corpus callosum. That's certainly the largest, connects the entire right and left hemisphere of the brain. And remember, I showed you the picture. If you put your fingers into the interhemispheric fissure, they rest right on the corpus callosum. So it's the floor of the interhemispheric fissure. And if we were to keep cutting down through the corpus callosum, we would get to this large fluid-filled space called the lateral ventricles. Okay, so your handout has these labeled. There are 4 parts of the corpus callosum, and I'll just show you here. We have a rostrum, a genu. Remember, a genu is a bend. Okay, a body, and then back here, a splenium. Okay, and it's really hard for me not to get into some of the interesting things. There's a fascinating scenario that happens if you have a lesion of the splenium of the corpus callosum, but it takes a lot of understanding of neuroanatomy to make sense of that, so we'll talk about it later. A really nice dissection showing you the corpus callosum and just the massive interconnection, and we'll talk about some of the syndromes that can result if you disconnect the right and left hemispheres. Okay, a much smaller commissural pathway is the anterior commissure. Okay, and it always has the same appearance. It's the only pathway in the brain that kind of looks like this. It connects structures on the temporal lobe on each side. Most important, the hippocampus, or the hippocampal formations, which again we're going to talk about here in just a few minutes. Hippocampus, we'll say, is very important for memory, and so the areas in the right and left hippocampal formations are able to communicate with each other via the anterior commissure. Okay, so here's another appearance of the anterior commissure. The smallest commissural fiber, boy, you can hardly see it there. If I use my laser pointer, I'm going to obliterate it. But it's the posterior commissure, and it's just that tiny little area right there. Let me just show you a little larger. That's it, just that one little white matter pathway right there. And the posterior commissure when we do our brain dissection, we'll say it's right between the diencephalon and the midbrain. Well, we haven't learned about the diencephalon yet, but the diencephalon is this area right here. The midbrain is right here. So the posterior commissure is this tiny little white matter pathway in between. Okay, and we'll see that the posterior commissure has a role to play in your pupils constricting to light, interestingly. And later on, we'll draw out that pathway. Okay, next in our telencephalic structures are the basal ganglia. Okay, and the basal ganglia are deeply located neurons. Okay, they're not out around the surface like in the cortex. They're buried deep in the white matter. And the best description of the basal ganglia is that they select wanted patterns of movement and suppress unwanted patterns of movement. And so lesions then of the basal ganglia result in movement disorders. And patients shake and have tremor, and I'll show you videos of all different types of movement disorders. Parkinson's disease, probably the one you're most familiar with. And patients with Parkinson's have a tremor, and that's a dysfunction of this, the basal ganglia circuitry. So there are three parts of the basal ganglia that are part of the telencephalon. First two I'll mention are the caudate and the putamen. Okay, the caudate is usually very easy to identify. It's a large nucleus. It bulges into this space here that we're going to talk about tomorrow. This is part of the lateral ventricle. Okay, so this is the caudate. The putamen is out here. Okay, notice, you've got the cortex out here, and then you've got white matter that's deeper, and so the basal ganglia are kind of in this very deep location. So caudate and putamen are two very large telencephalic components of the basal ganglia. And if we cut down a little bit further, we come to the third telencephalic portion, and that's called the globus pallidus. Okay, so again here we see the caudate, the putamen, and can you see there's like a little separation? This looks a little darker, this looks a little lighter, so this whole area right here is the globus pallidus. Okay, later on we will draw out the circuits of all of these basal ganglia structures and explain how it works. So for now, just to recognize what they look like. So we lump together different parts of the basal ganglia. We use the term the lentiform nucleus. This means lens to refer to the putamen and globus pallidus together. You can kind of see it has this lens shape right here. So the lentiform are those two together. That's really not clinically significant at all. It's more just how they appear. What is more relevant really is to understand that the striatum refers to the caudate and the putamen together. And the reason that's actually more important is this is the functional unit that works together, the striatum. Okay, the putamen and the globus pallidus just happen to be next to each other. Okay, but the striatum, the reason we want to lump those two together is, as a big picture, when the brain, the cortex, talks to the basal ganglia to facilitate movement, it talks to the striatum. Okay, so the striatum is the input nucleus of the basal ganglia. Okay, and so then all this happens, this information is shared among the different areas of the basal ganglia, and then when the basal ganglia talks back to the cortex, the output nucleus is mainly the globus pallidus. So this is communicating information back to the motor cortex. So just another picture here showing you the caudate, the putamen. Remember, that's the input nucleus, and the globus pallidus here, which is the output nucleus of the basal ganglia. Okay, and this is a section that is done like this. We call this a coronal section that is cut through the brain, and the caudate is here, and even if you're disoriented, you don't know where you are in a section, if it's a big nucleus bulging into the lateral ventricle, it's the caudate. So that's the caudate, and we can see there are these striations, these connections between the caudate and the putamen. That's why it's called the striatum right here. All right, now the caudate is one of many C-shaped structures in the brain. And this is what often confuses students, because Here's the caudate. It has a head, a body, and a tail. Okay, so this whole thing is the caudate. What makes it confusing is what happens when you cut through a C. Well, you're going to see it in two very different locations. So when next week, when we actually begin to do some cutting, you'll see the caudate here, and now it's way over here. How can it be in two totally different locations? And so you just need to remember, you know, if we're cutting this way or if we're cutting this way, you're going to see the caudate in all different kinds of places. So it's helpful just to recognize as we go through what are C-shaped structures. And so you're kind of prepared for that. All right, so the caudate we can see here. Okay, and in blue, this is the putamen. Okay, and the thalamus and some of the other structures we'll come to in just a little bit. And just interesting, there are just a handful of individuals, probably no more than 10 in the world, who have what's known as total recall. This is a famous actress, was in a TV show called Taxi years ago. And these individuals have just an encyclopedic memory of every day of their life. And you could just tell them, August 4, 1973, what were you doing? And you can Google this and interesting interview with her, and she can tell you everything, every single day, exactly what happened. And what's fascinating about all of these individuals is they've done tests on them. They all have a very large caudate nucleus. Now the caudate, I've just been telling you it's part of the basal ganglia. It's important for movement. Well, obviously there's something more to the caudate than that, because it has something to do, these individuals with their incredible memory have a very large caudate. So it's just kind of an interesting fact there. So the basal ganglia, we're going to use our internal capsule as an important landmark for identifying different parts of the basal ganglia. So rather than reading that, let's just look at it here. Here's the internal capsule. Remember the anterior limb, the genu, and the posterior limb. All right, so notice that the anterior limb separates the caudate from the putamen and globus pallidus. Okay, here's the genu. The posterior limb separates the putamen and globus pallidus from this large nucleus here that we'll come to in just a few minutes called the thalamus. So it will be very helpful when we do cutting, identify the internal capsule, and then just kind of work from there. And we can identify things that are in and around the internal capsule. All right, now the globus pallidus itself has an internal and an external portion. And so I think you can appreciate the separation here between the putamen. There's a little separation there. And then this is the globus pallidus. Well, the globus pallidus actually has an external part and an internal part. And you can see this is a little pale right there, a little bit darker here. And this is actually pretty important when we talk about Parkinson's disease. A real growing area in the treatment of Parkinson's is called deep brain stimulation, where we put a little probe in the brain and we electrically stimulate that part of the brain, and patients can have often just a miraculous improvement doing that. Well, it turns out the probe most often goes in that internal part of the globus pallidus, and we'll explain later why that area seems to be most effective. So there's an internal and an external segment, and as I mentioned, the globus pallidus is the output nucleus. This is how the basal ganglia communicates back to the cerebral cortex. And here we can see very obviously here the separation between the putamen and globus pallidus. Okay, there are several non-telencephalic components to the basal ganglia. One is the substantia nigra, which is in the midbrain. Okay, and if you go back to the table on the first page of the embryology of the brain, the midbrain is equivalent with the mesencephalon. So the substantia nigra, therefore, is of mesencephalic origin, and this is the part of the brain that degenerates in Parkinson's disease. It's more complex than that. There are other areas that are involved in Parkinson's, but for now, when you hear substantia nigra degeneration, the patient has Parkinson's disease. And this is something that shows up quite easily when we do brain sections because of the darkly staining neuromelanin. And so you can readily identify the substantia nigra, and at autopsy, a pathologist can just look and see, are there a lot of pigmented neurons in the midbrain? the patient doesn't have Parkinson's disease. If there is an absence, then the patient probably has Parkinson's disease. Okay, there's a nucleus of the thalamus called the subthalamic nucleus. Remember, anything with the name thalamus in it is of diencephalic origin. And this is also important in basal ganglia circuitry. And remember, diseases of the basal ganglia result in movement disorders. Parkinson's disease, think of Michael J. Fox. He has a tremor, movement disorder. A lesion of the subthalamic nucleus results in what's called hemiballismus. And so if patients have a lesion there like a stroke, the opposite side of the body has these wild ballistic flinging movements. Okay, and later on I'll show you a video of a patient I saw just last year that had hemiballismus. And so you see a patient like that, you can be very confident you know exactly where the lesion should be when you order that MRI scan. All right, so here in one section we can see all the different components of the basal ganglia. And I know this is difficult because you're not oriented, where are you? And so we just have to kind of get immersed into this. But here we're looking at the caudate. Remember, it's bulging into the lateral ventricle. Out here is the putamen and the globus pallidus. And as we go deeper down, we come to a nucleus here and over here. It usually has kind of a shape of a football. Okay, and that is the subthalamic nucleus. And if we go a little deeper down, notice the darkly staining here, pigmented neuromelon pigment there. This is the substantia nigra. All right, where's the substantia nigra? It's in the midbrain. So that means this whole section right here that we're cutting through or looking at is the midbrain. Okay, so these are the most important areas of the basal ganglia, and they all function together so that we have very smooth, coordinated movements. Okay, it may be helpful without, here are the arrows, but can you see here in the globus pallidus, can you see a little white striation in the middle? And so we've got an external and an internal segment. Okay, I need to find out if I can do a smaller pointer there to better show that. And again, notice the kind of football-shaped nucleus there, the subthalamic nucleus, and the substantia nigra. All right, next is the limbic system. Okay, limbic system consists of cortical and subcortical prosencephalic structures that we find mainly in the medial aspect of the hemispheres. Now that's a lot. What does that mean? Well, what's the prosencephalon? We just go back here. Prosencephalon consists of the telencephalon. Okay, we've been through this much of the telencephalon, and the diencephalon, which is anything with thalamus. Okay, so limbic structures are going to consist, in this category here. Okay, HOME is a good way to remember the basic function of the limbic system. Okay, the hypothalamus is an important part of the limbic system, and that's the head ganglion of the whole autonomic nervous system. So homeostasis is part of the autonomic system. Your sympathetics and parasympathetics, regulating, blood pressure, respiration, all kinds of things. And also the hypothalamus controls the pituitary gland, so neuroendocrine function then is a function of the limbic system. Olfaction, this would probably be the least important. Well, we shouldn't put down smell, but that's a part of the limbic system. And memory and emotions. These are probably the two that you'll remember most easily because we'll spend more time on them. Laying down new memories is a function of limbic system pathways, and also the unique way each of us respond to emotional input, the degree of anxiety or other disorders. If there's dysfunction, are lesions or degeneration or dysfunction of the limbic system. So the terminology here can be a bit confusing. Some refer to a limbic lobe, and the limbic lobe consists of the hippocampal formation, the parahippocampal gyrus. Okay, we pointed that out this morning, and the cingulate gyrus, which we also pointed out this morning. Okay, but there's a system that involves several other areas. I think the distinction here is probably not that important, but you do need to know each of these areas and that they're all part of the limbic system working together. So the amygdala, the nucleus accumbens, the hypothalamus, and a nucleus of the thalamus called the anterior thalamic nucleus. All of these together constitute part of the limbic system. All right, so what have we seen here that's part of the limbic system? Well, remember there's the uncus, and so if we move out laterally, that's the parahippocampal gyrus. So when you think about that gyrus, it's part of the limbic system, and especially would be important probably for emotions and somewhat for memory. Okay, now to see the other parts of the limbic system, we actually need to do some cutting. So here's the temporal lobe, and so if we were just to cut into the temporal lobe, we'll find other components of the limbic system. So if we just cut off the tip of the temporal lobe, like this, what we first come to is the amygdala, which means almond. It's kind of an almond shape, a homogeneous nucleus right there. So the amygdala, the amygdaloid complex. If we were to cut back further into the temporal lobe, the amygdala disappears, and now we come to the hippocampal formation, which really extends back for a very long distance here. Okay, so the amygdala and the hippocampus we'll find in the temporal lobe. Okay, so again, the amygdala is kind of in the anterior portion of the temporal lobe, and as we keep going back, then we come to the hippocampus, and we'll follow that all the way back. All right, so next week, when we do this cut right here, we don't have enough brains to make a section through an entire brain, so we'll have you do this on half of a brain, and we'll make a cut right here. And notice we're cutting off the tip of the temporal lobe right here. So this is the cut where we'll hope to see the amygdala, right about in that location. So when we make that cut, so here's the tip of the temporal lobe, right in there you can see there's just a homogeneous nucleus there and also there. So that is the amygdala. As we go back, now we go one cut further back, we don't see the amygdala anymore, we see the hippocampus. And when you can see this with the naked eye, it'll stand out a little more, but can you appreciate, I kind of hate to use this terminology, but some have said it's like a jelly roll here being kind of rolled up. And so amygdala is just homogeneous. The hippocampus, you can actually kind of see it swirling around. All right, so other parts of the limbic system. Remember the cingulate gyrus we've talked about, which sits right on top of the corpus callosum. That's part of the limbic system. And the hypothalamus is in this location here. We're going to point that out again when we get to the Diencephalon, but there is your hypothalamus. All right, so let's just a cartoonish drawing here of the hippocampus. So remember, it curls around, kind of like this. So at the tip, we have the dentate gyrus. Okay, and then the hippocampus consists of these different sections, CA4, 3, 2, and 1. And then there's a subiculum. Okay, so but most people, they'll just call it the hippocampus. Okay, or the hippocampal formations. Either one would be appropriate, even though technically they're different parts, dentate, hippocampus, and subiculum. Okay, and all of this is right adjacent here to the parahippocampal gyrus. All right, and so just a drawing here, again, is the dentate, these different portions of the hippocampus, the subiculum, and the entorhinal cortex, which is probably part of the parahippocampal gyrus, is immediately adjacent here to the hippocampal formations. And it turns out that anything going in or out of the hippocampus, probably the entorhinal cortex here is the gateway to the hippocampus. All right, so we said that the limbic system is important for laying down new memories and converting those memories into long-term memories. And so if we have damage or destruction, especially of the hippocampus, then there's going to be a problem with memory. So such as declarative memory. This is what you're doing right now, learning facts, the names of things. That's very, very difficult if you have a problem with the hippocampus. Alzheimer's disease would be the classic condition that affects the hippocampus. And as you know, these patients have a lot of memory loss. Non-declarative memory would be skills that you've learned. You learn how to ride a bike. You know, that's not facts. You kind of know how to do that. So that's kind of the difference between declarative and non-declarative memory. If we have a damage of the hippocampus, very hard to store short-term memory. And short-term memory is mainly affected in Alzheimer's early. They can remember things from decades ago, but, you know, what'd you have for breakfast this morning? They can't remember. It's a recent thing. It's laying down new memories. It's difficult. And interestingly, the hippocampus, this is a relatively recent discovery, is really a GPS map. Your sense of orientation, remembering streets and things, is a function of the hippocampus. And so an early feature of Alzheimer's disease is patients get lost driving. Okay, they're off somewhere and they can't remember how to get home, even though they've maybe taken that route several times. And so tie that in with the hippocampus. And this was a Norwegian several years ago who won the Nobel Prize in science for, and it's very, very detailed, but just showing how the hippocampus, every place you go, there's a specific route that is just laid down kind of on this hard drive here in the hippocampus that gives you a sense of direction. So there's a pathway that is probably important for laying down new memories. And so it's called Papez circuit. So the student who drew this for me, it's the Papez racing circuit. So we'll kind of follow this from beginning here in the hippocampus, okay, and it ends in the hippocampus. But here's the pathway. So it goes in the hippocampus, and the connection here is called the fornix. Okay, and we'll see this in the lab, but it connects the hippocampus with an area of the hypothalamus, MB, which are the mammillary bodies. Okay, that's the first loop here of the circuit, from the hippocampus to mammillary bodies. Okay, the next part goes up to the thalamus, to a nucleus called the anterior thalamic nucleus. Okay, later on we'll go through each of the individual thalamic nuclei, but it's the anterior thalamic nucleus that is part of the limbic system. From there it goes up to the cingulate gyrus, and from the cingulate gyrus back down to the hippocampus. Okay, and it isn't really known how does this circuit, how is it actually involved in laying down memories? Well, it is, but a lot of that is still a mystery. But remember, the cingulate gyrus here is then important for memory function. It's part of the Papez circuit. Okay, so here's just another drawing of it showing you the hippocampus, fornix, the mammillary body, the anterior nucleus of the thalamus, the cingulate gyrus, and then back down to the hippocampus, which remember is adjacent to the parahippocampal gyrus. And there we've got this entorhinal cortex, which remember I said the gateway in and out here of the hippocampus is that entorhinal cortex. Okay, and there's the amygdala here just sitting anterior to the hippocampus. Okay, and I'm sorry I can't find a better drawing than this, but it's just helpful for orientation in our lab to just recognize that the hippocampal formations are out laterally in the temporal lobe, but the hypothalamus and the mammillary bodies are medial. And so this first loop of Papez circuit goes from a lateral structure, the hippocampus, and via the fornix goes down to a very midline structure here, the mammillary bodies. All right, so the amygdala. Psychiatrist Dr. Perot gives you a lecture here in a month or so on the limbic system anatomy, so you get this in a lot more detail. But the amygdala, we say, is very externally focused. Very important part of the brain for emotions, responds to the environment, and when we talked about the autonomic nervous system, remember I said this is like the fire alarm switch, that when it gets turned on, it activates the hypothalamus and the sympathetic system, fight or flight. Okay? And so its output is to the hypothalamus, and that pathway, which is very, very small, we'll see it in the lab, but it's called the stria terminalis. So this is how the amygdala is able to activate your hypothalamus for fight or flight. Okay, that's the pathway, stria terminalis. So if we have a lesion of the amygdala, and it usually has to be a lesion of both right and left amygdaloid nuclei, then this is associated with impaired threat assessment. Because remember, this is the fire alarm switch. So if you have a lesion there, there's just less response to things that should normally activate your sympathetic system. And this is part of Kluver-Bucy syndrome. There are several other aspects to it, so I'm not going to tell you the whole syndrome for now, but that's one part of it. And in the lecture on the autonomic nervous system, I told you that PTSD, patients that have post-traumatic stress disorder, have an abnormal activation of this amygdala to hypothalamus loop. So it doesn't even take a threat, something that is real, to cause panic. There's just an oversensitivity. And so just a thought or something can trigger panic attack and anxiety, memories of things that happened in the war or whatever. All right, so here's the amygdala, and in purple we can see the stria terminalis. This is the pathway, and it follows in parallel with here the caudate, and also with the fornix pathway for the hippocampus to the mammillary bodies. So the stria terminalis goes down to the hypothalamus. That is not shown here, but just this much of the loop. All right, another part of the limbic system is the nucleus accumbens. Okay, where's the nucleus accumbens? Well, the caudate nucleus is here in green. Remember, that's a C-shaped structure. And the nucleus accumbens is found right at the tip of the head of the caudate. All right? And again, I realize this is difficult here, so I'm just going to show you a picture with no orientation. We haven't done our brain dissection labs yet. But here's the caudate and the putamen. Those we've looked at already. And the nucleus accumbens is right here. Okay, so we'll have to spend some time that, persuading you that how you can find it there. But I'll just show it for now, and then in the lab, we'll hope that sinks in better. So what is a nucleus accumbens? It gets projections from both the amygdala and the hippocampus, okay, and from an area in the brainstem called the ventral tegmental area. Sorry, we're not at the brainstem yet, but we'll talk about the ventral tegmental area. And a lot of these are dopamine projections to the nucleus accumbens. Lots of dopamine. All right, and so in a healthy sense, the nucleus accumbens is associated with reward and motivation systems. We use the term, how do you get your dopamine? Well, this is dopamine going to the nucleus accumbens. So if you get a drive from, being organized or whatever, well, it's the nucleus accumbens that is doing that. It's known, there have been some good, very recent studies which are very interesting. The intense pleasure and satisfaction, a piece of music that you really like, and that you just get excited by that. It's the nucleus accumbens. It's very active in that experience. In dysfunction, it's abnormally activated in addiction, a lot of drug addiction, smoking, and so on. It's abnormal activation of the nucleus accumbens. And later on, when we talk about Parkinson's disease, we give dopamine medications to patients with Parkinson's disease. And that can often abnormally excite the nucleus accumbens. I'm oversimplifying things here, but that's part of it. And that can result in what's called impulse control disorders. This is very common, actually. Up to 30% of patients on these medications will get this. And it can take the form of gambling or other addictions. I have some older vets with Parkinson's that start, just a fixation on video games, like a teenager would play. And they'll play them for 8 hours a day. And it's the dopamine nucleus accumbens abnormal stimulation that can result in these impulse control disorders. All right, so up here we have the cingulate gyrus, and so remember, as far as a system, the cingulate gyrus is part of the limbic system. So we've said it's part of Papez circuit, so it is important for memory, but it's also very important for emotions and emotional processing. Years ago, it was suggested, when we use the term like, I love you with all my heart. Well, the heart is a muscle that pumps blood. It really doesn't have that kind of emotional. And some have said, well, the cingulate gyrus, maybe that's the best candidate. If we're going to speak anatomically correct, you know, I love you with all my cingulate gyrus. But it's probably, there are other areas, but this would certainly be an important part of that. All right, and then finally the olfactory system, which we'll say very little about. We've already pointed out the olfactory bulb and tract. There's a little connection back to the uncus called the olfactory stria. And remember, the uncus is primary olfactory cortex. And we haven't talked about the thalamus yet, but when we do, in a few minutes, I'll tell you that every bit of sensation going to the brain has to go through the thalamus. It's like a filter. It's like a gateway. Interestingly, smell is one sensation that doesn't need to go through the thalamus. It just bypasses it and goes right to a part of the cortex here, which is the uncus. Okay, the amygdala is also right next to the uncus. And it is amazing. I mean, you think about the amygdala with emotions. If you've ever experienced the smell of something that maybe you haven't experienced in 10 years, and immediately all these memories and emotions from that smell of childhood or whatever come back to you. And probably that is, you know, just anatomically here, the amygdala and the uncus have such a close relationship. Okay, so here's the olfactory bulb and tract. And you can't see here, but there are these little stria, olfactory stria, that connect the olfactory tract with the uncus right there. Okay, and now in a drawing we can see these little strial connections here from the olfactory tract going back to the uncus. Okay, one thing I'll just mention briefly about the uncus. It turns out this is the most epileptic part of the brain. So when we talk about seizures later, they often will begin in this part of the brain. And a seizure is like an electrical storm, where there's just excessive electrical activity. And so you can imagine then, what would someone with a seizure that begins here, what would they first be aware of? Well, it's usually intense odor, and it's always unpleasant. It's like burning rubber or something really unusual. And so that's, if you have a patient with epilepsy and they tell you it starts out with a foul odor, well, you know where the seizures begin, right here in the area of the uncus. Okay, just a few things on directional terms here. All right, because as I show you these, it's helpful if I can just tell you a horizontal cut and you know what I mean, a coronal cut and you know what I mean. So a horizontal section would be like this. Okay, our first lab next week consists of doing horizontal cuts through the brain. Our last lab will be coronal sections, where we're making a cut like this through the brain. Okay, and also when we do MRI and CT scans, we'll be looking at horizontal and coronal sections. A sagittal section is usually just a single midline cut like this. Although with MRI we can do very detailed, we can move out laterally in terms of sagittal sections. Right, so what kind of cut is this? These are horizontal sections through the brain. Coronal would be like this. So those are horizontal cuts. One other thing that's helpful in terms of terminology, it's easy with the spinal cord. You know, we have anterior and posterior, or ventral and dorsal. But the brain itself is a C-shaped structure. And so we have this, what's called a rostral-caudal axis, which goes like this, from rostral to caudal, rostral to caudal. And so this axis here between anterior posterior or ventral dorsal curves along with the rostral-caudal axis. Okay, and so now we have ventral dorsal. So it curves kind of along with the rostral-caudal axis. And this is just helpful when we're pointing out, well, I'll give you a few examples here in just a bit, but we'll say something is ventral to this, and that you kind of know what that means. All right, so we've been through the telencephalic structures, and now we move on to the diencephalon, which is a lot shorter. So we go from the telencephalon down to the diencephalon. Diencephalon sits right on top of the midbrain. And so we say it's just rostral to the midbrain. Well, here's the midbrain, and all of this is the diencephalon. So remember, our rostral-caudal axis And so the diencephalon here is just rostral to the midbrain, which is here. Okay, so everything in this area right here is of diencephalic origin. Remember, there is a ventricle associated with all of these embryologic categories. And so the third ventricle is what we will see as a midline structure for the diencephalon. And again, we'll use the internal capsule, especially the posterior limb here, as an important landmark for the diencephalon. Right, so here's the posterior limb of the internal capsule. Right, and so the thalamus here is medial to that. Right, so this is the thalamus right here. That's the largest part of the diencephalon. Okay, smallest part of the diencephalon is what's called the epithalamus, which consists of the pineal gland, which I'll show you in just a minute. It's just above the dorsum of the midbrain. It secretes melatonin, and when we talk about sleep later, we'll explain how release of melatonin or not releasing melatonin is important for sleep-wake cycles. All right, so I said it's just above the dorsum of the midbrain. So here's the midbrain, so this would be the dorsum of the midbrain, and so right above that is the pineal gland. Okay, so it sits right there. Okay, the other parts of the diencephalon, here we have the thalamus, and here's the hypothalamus. Okay, there is a habenular nucleus. It's part of the epithalamus, but not really known what it does. It's hard to see, so I won't ask you about that. Okay, so the thalamus itself is the largest part of the diencephalon, and it lies between the third ventricle and the posterior limb of the internal capsule. And I'll show you that again here in just a second. We will see in the lab that there's often a big adhesion, a connection between the right and left thalamus. That appears to have no clinical significance, but just because we'll see it in the lab, I point it out. And so there's a thalamic nucleus for everything, for sensation, for vision, everything except smell. And so we will eventually, you will know all of these individual thalamic nuclei. For now, we're just going to point out a few. The only one we've mentioned so far is the anterior thalamic nucleus. Remember, that's part of Papez circuit for the limbic system. Okay, the thalamus is sometimes called the executive secretary of the brain because it regulates what is important enough to tell the brain. Let's think about it that way. All right, so at times, like right now, if you're really concentrating, you only want to just focus on what's going on in the lecture. Well, you really don't want your brain bombarded by sensation in your left foot or things like that. So your thalamus effectively can shut everything else out so that you're able to really focus in on something. Okay? If you're woken up at 2 in the morning by a noise outside, and now you want everything. You want every sound. You want every sensation, vision. You want everything in. So then the thalamus would allow access to all sensations. So it's able to regulate what gets to the cortex. So the thalamus, we said, is medial to the posterior limb of the internal capsule. There's the posterior limb, and there's the thalamus. And then here is the space, the third ventricle. Remember, the third ventricle is associated with the diencephalon. Here's the lateral ventricle, and that is associated with the telencephalic structures, like the caudate nucleus. All right, so again, we have got the pineal gland here, the thalamus here, and then the hypothalamus is up here. Okay, and just a close-up here to show you the thalamus and the third ventricle. And here's an MRI scan where you can see nicely the internal capsule, and the thalamus, and the putamen, and the caudate. Right, the hypothalamus is ventral to the thalamus. What does that mean? Well, dorsal, ventral, right? So there is the hypothalamus, ventral to the thalamus. Okay, so this whole area, okay, and here's the thalamus, and so all of this in this area here is the hypothalamus. And there are a lot of things to see around the hypothalamus. And so we're going to spend some time when we do this sagittal section pointing all of these things out. It's a little overwhelming right now, but let's just do it anyway. All right, so above the hypothalamus, there's a pathway right here, and that is the anterior commissure. The anterior commissure, we said, connects the hippocampal formations. And so as it crosses over, we look for it just above the hypothalamus. Okay, on the floor of the hypothalamus, we see the mammillary bodies. Remember, that's part of Papez circuit. Okay, it's the nucleus of the hypothalamus. It sits right there. And then at the most ventral portion here, there's a pathway, and this is called the optic chiasm, which you don't know anything about yet, but there it is. Okay, so these are just some landmarks here that will help us to identify the hypothalamus. Okay, and Dr. Kirby will give you a lecture in a couple of months to go through each of the hypothalamic nuclei, what they do, and their function. So that's for later. So as a big picture, the hypothalamus, remember, it's part of the limbic system, so we've talked about it's the head ganglion for autonomic, neuroendocrine, and we will see that the hypothalamus is important for regulating, whether you're hungry or full, body temperature, your sleep-wake cycle, and circadian rhythms are all a function of the hypothalamus. Okay, and then finally, the other part of the diencephalon is the subthalamic nucleus. So remember, embryologically, it's of the diencephalon, but functionally, it's part of basal ganglia circuitry. And remember, a lesion there will give a patient hemibolismus. So again, there is the subthalamic nucleus right there. Okay, and let's spend a few minutes here talking about the brainstem. And I just found out before the lecture that I guess we have a new individual sectioning the brains for this lab, and I was told we may have lost a lot of the brain stems because they made the cut a little too high. So I'm going to find out here this afternoon, but that would be too bad. So we may have a hard time in the lab seeing some things in the brainstem. But I think most of this can be done here with an atlas, so we'll just have to do the best we can. But the brainstem, we have 4 hours later on brainstem anatomy. It's one of the more difficult areas because there's so much in the brainstem, so many pathways, so many nuclei. So what I do now will just be a very brief overview. So we have sensation from the arms and legs going up to the brain. That has to go through the brainstem. We have descending motor pathways to move your arms and legs. That has to go through the brainstem. Autonomic pathways have to travel through the brainstem. We have these massive connections between the brain and the cerebellum. Those all route through the brainstem. And you've got cranial nerves 3 through 12, okay, which we'll find in specific areas of the brainstem. And then we have something called the reticular formation, which I will tell you in a little bit the function of that. Maybe a take-home point, though, would be that if you have a lesion in the brainstem, it can often result in very devastating consequences. It doesn't have to be very large. You can have a small lesion in the brainstem and the patient may be in a coma because there are so many critical pathways in one small area. Whereas we see all the time a patient will have a stroke in the brain and they have no symptoms of it. You only find out because you did a brain scan later. And so that's usually not the case with brainstem lesions. All right, so the upper portion of the brainstem is the mesencephalon, otherwise known as the midbrain. Okay, so it lies between the diencephalon, which we just covered, and the pons, which is just below. Okay, and there are 3 main areas of the midbrain. First, we have the cerebral peduncles. These are anterior or ventral. Okay, and the cerebral peduncle is a continuation of this pathway I pointed out in the posterior limb internal capsule. Remember the corticospinal tract, the pathway I said we'll talk about more than any other? Well, as it goes down through the posterior limb internal capsule, as it moves into the cerebral peduncle, or into the midbrain, it travels through the cerebral peduncle. Okay, this is one of the hard parts of neuroanatomy. It's the same pathway, but it keeps changing names depending on what level we're at. So once it's in the midbrain, we call it the cerebral peduncles. So it's the continuation of the descending motor fibers in the posterior limb and genu of the internal capsule. Well, remember, what's in the genu? The cortical bulbar tract. So these 2 pathways together continue down into the cerebral peduncle. Okay, when we've identified the cerebral peduncles, there are two cranial nerves that we want to find around the cerebral peduncle, cranial nerves 3 and 4. Right? So here's the midbrain right here. Now the cerebral peduncle, I said, is anterior or ventral. We actually don't see it here. What you would need to do is to put your finger in that space and kind of push in, and then you would touch the cerebral peduncle. Okay, so where's the midbrain here? Well, you can't see it. Here's the pons. The midbrain is deep in here, so we have to pull the temporal lobe apart and look deep to find the midbrain. So if we did that, if you took your hand and you pulled the temporal lobe away, there's a massive pathway right there. And that pathway is called the cerebral peduncle. It's a huge, peduncle is a pathway. Okay, so the cerebral peduncle contains these two pathways, the cortical spinal tract and the cortical bulbar tract, as they continue down from the internal capsule. Okay, that's probably a good place to stop, and see you tomorrow.